because this can make the difference between an easy intubation and one that is quite challenging. So here we have a guy laying on the bed, and he is very poorly positioned. This is his oral axis, so oral axis. His pharyngeal axis follows the course of his pharynx, so that's there. And this is his laryngeal axis, follows his trachea and his larynx. And you can see right now that the oral axis is basically straight up and down, and his laryngeal axis is horizontal. Remember, for direct laryngoscopy, the idea is that you want to be able to stand at the head of the bed and get a direct view down to the cords. But right now, if we were to just look through his oral axis, we're staring straight at his posterior pharynx, and that's not going to get us very far. So let's try to get better alignment with these axes. First position change is cervical flexion. So what we've done is put a pillow under the head to facilitate flexion of the cervical spine. And what this has achieved is changing the angle of the laryngeal axis here. So previously, the difference between the pharyngeal and the laryngeal axis was much wider. Now this is much more of an acute angle because we've changed his laryngeal axis. And then next, we'll put the patient into Atlanto occipital extension. So have them tilt their chin up to the ceiling or push their head down. And this helps align our oral axis. So previously it was more straight up and down, and now there's much more of an acute angle between the pharyngeal axis and the oral axis. And now you can see in this final position with the cervical flexion and occipital extension, the alignment of our airway axes is much better than when we started out over here. So this is much better for standing here and getting a direct line of sight down to the cords. Essentially, the only thing in our way at this point is the tongue, which just needs to be displaced into that submandibular space. And that's what our laryngoscope is for. This is the Mac blade, or Macintosh blade, which is a curved blade, and this is the handle here, which you'll hold on to with your left hand. There's a light on the end, so you can see what you're doing when you get inside the airway. This specific blade is designed to be held in the left hand because you can see on the right-hand side, we're looking down the barrel of the laryngoscope here. On the right-hand side, there is this channel which facilitates your view down the right-hand side and also makes it more easy for you to pass the endotracheal tube down the right-hand side there. So to intubate someone, you'll start by looking at them, and this is sort of the view you'll have. You're going to put your right hand on their head, and so from this side, this is what you'll do, is put your right hand and force their head into AO extension. And so you're going to keep your right hand there pretty much the entire time until you're ready to grab your endotracheal tube from the assistant. So just keep your right hand on their head while you insert the laryngoscope through their mouth. So what you'll do is you'll put it down sort of on the right side here. And that's so that the tongue is displaced left in the mouth and it is not obscuring your view through this channel here on the right-hand side of the laryngoscope. And so from the side view, you'll just see the idea is that you're putting the tip of that blade right into the vallecula and then lifting. So you're going to pull up and away from you, sort of aiming at where the ceiling meets the wall on the other side of the room. So out in this direction in order to displace the tongue into this submandibular space and further pull the mandible away to open up this view. What you don't want to do is rock this back. Do not do that because the patient will have upper teeth here, and you don't want these teeth to make contact with the metal blade. That would very easily cause dental damage, which we want to avoid. So after you've pulled on the laryngoscope, hopefully this is all displaced and you'll get a good line of sight. And so what you'll actually be looking at here is your glottic view, which I've drawn for you here. And the ease of which you can see these glottic structures is graded on this scale called the Cormack-Lehane grading system. And so this is the best view you'll get. Everything is very clearly visible, and that's your grade 1 view. And I'll label this diagram for you so that you have frame of reference for what we're looking at. So this is the base of the tongue. You would have first seen that you're advancing your blade along the tongue here, and then you've got the tip of the blade right in the vallecula, which is where the base of the tongue meets the epiglottis. So of course, this is the epiglottis. And by doing that, you've successfully lifted the epiglottis up. If you do not get your tip of the blade right into this vallecula, it doesn't properly engage the hyoepiglottic ligament, and you may have an issue where the epiglottis is not flipped up appropriately. But this is a good view. So we've got the true chords here. And then between your chords, you'll be able to see into the trachea. So this is the anterior trachea that you're looking at, and those would be tracheal rings. You might be able to see those. This paired cartilage here is called the arytenoid cartilage. And there's another cartilage that sits right on top of that. And then a second set of paired cartilage here called the cuneiform. This fold that connects your arytenoid cartilage to the epiglottis is the airy epiglottic fold. And then you are even able to see here where the anterior part of the chords meet each other. So that's your anterior commissure. This little slit here is the esophagus, which will, it's not going to really look like much, but it is there. And you can see, obviously, that's a different hole than where you're aiming your endotracheal tube. So you don't want to be intubating the esophagus. This grade thing is the Mac blade, in case that wasn't clear. So a slightly worse view than this would be our grade 2A. And you can recognize, hopefully, the similar structures here, but now we have only partial view of our chords. So we can't see the anterior commissure anymore. It's covered by the epiglottis. And then we can maybe see about half of our chords. So here we have partial chords. And then slightly worse, again, is a grade 2B view, where now we maybe can see just the bottom of the chords, but really what we're seeing here is the arytenoids. So we're in the right territory. Like, you know that just above or just anterior to this will be your vocal cords, but you can't quite see them because the epiglottis is folded over top. And grade 3 view is even worse. Your entire glottic view is obstructed by the epiglottis. So you can't see the arytenoids, and you can only see epiglottis. And just like I said, if you have not properly advanced the tip of your Mac blade into the vallecula, perhaps this is the reason that you've not engaged the hyoepiglottic ligament and the epiglottis has remained flopped down over top of your glottic view. There also is a grade 4 view, but that's just no glottic view whatsoever. So, I mean, maybe you'll be able to see like just the tip of the epiglottis, but this is a very poor view and quite rare. So sometimes you will put your direct laryngoscope in, and this is the view you'll get. So it's close, but not quite there. We talked about making sure you're getting the blade tip inside the vallecula, but another maneuver you can do to help out is called burp. This is back, up, right pressure. So you are going to do this. So before you grab your endotracheal tube from your assistant, you'll decide if you like your view or if instead you're going to manipulate the neck. So the back up right pressure is over top of the thyroid cartilage on this patient. So back, you'll push down on that. And hopefully by doing that, you will displace the glottis below what is obstructing it here. So you're going to push it down below the epiglottis, and then you will improve your view. So that's the back pressure. Up, just a little bit like this, and then so that can advance the glottis more towards you. Basically, it doesn't move it much, but it can help. And then right. So the reason you're doing that is because technically you're kind of looking on the right-hand side because of the way the MAC blade is designed. So by moving your whole glottis to the right, maybe that will facilitate your view and the pressure. Back, up, right pressure. And so this is pressure that you apply to the neck, but it is different than cricoid pressure. So it's not the same thing. Cricoid pressure is pressure that you apply to the cricoid cartilage in attempt to squish the esophagus and prevent gastric content regurgitation. Again, the burp is applied to the thyroid cartilage, and it's in attempt to improve your view for direct laryngoscopy. I think it's really important that you remember the Cormack-Lehane grading of your glottic view, because when you intubate someone, especially when you're just starting out, your preceptor will want to know what you see. And if you can clearly say, I have a grade 2A view or a grade 2B view, that immediately tells them that both you're able to recognize the glottic anatomy and should give them some idea of the ease at which you'll be able to actually intubate the patient, or if they'll need to take over. Now just remember that the Cormack-Lehane grade system is for your glottic view. We previously talked about the Mallampati score, which you were using pre-op to assess how well you can see inside the patient's mouth. And remember, those are different. It can be confusing because they're both scored on a scale from 1 to 4, but your Mallampati score is different than the Cormack-Lehane grade. I mean, as you can see, you use this to describe your glottic view. Okay, the last thing I wanted to show you is just a different technique of opening the patient's mouth. We talked about putting the head into the Atlanto occipital extension with your right hand underneath there. That should open their mouth, and you should be able to fit your blade in there, maybe with some help getting your lower lip off of the teeth. But this is sort of the scissor technique. So imagine you've snapped your fingers, and then your thumb is pointing up and your middle finger is pointing down. That's first and third finger. So now you can put your thumb on the lower molars and push the lower jaw away, and your third finger on the upper molars and push those teeth away, and you should be able to spread the mouth open by this technique. Now, disadvantage to this, obviously you're putting your gloved hand into the patient's mouth, so now that's not clean, and you're also kind of taking up a little bit of your room on the right side of the mouth, so it takes a little bit of practice to do this technique properly. I realized I've pretty much gone over everything except actually placing the endotracheal tube, so just a note on that. So this is your endotracheal tube. It'll have its connector up top and a cuff here with somewhere to inflate your cuff. I'm going to hold this about 2/3 of the way up, or closer to the top than the bottom so that you don't have to change position of where you're holding this when you insert it to an appropriate depth. And that depth for men is about 23 centimeters. And tube should be about 21 centimeters for women. Of course, different heights of people. Just be reasonable about the tube depth. And you will have to listen to the patient's chest to confirm that you have not inadvertently done a right mainstem intubation, so just for equal air entry on the left and the right hand side. And then you'll also get end tidal CO2 tracing to confirm. Now you're ready to tape the tube in place. And you're done. Now you just have to worry about getting anesthetic gas on board and starting your ventilator and doing everything else that we do. So just some tips. Other things we didn't talk about. Bed height is very important. So you should put the patient's head should be around the height of your waist, so a comfortable working height for you. And people have a tendency to want to get really close to the patient while they're intubating and get their eyeball right up against the patient's mouth to see in there, but you don't need to do that. Stand back from the patient, because just like the diagrams I've shown, you get the best view actually from a distance here, and it looks a lot less awkward. That means that when you're intubating, or when you're doing direct laryngoscopy, your arm is pulling away from you, so you're kind of engaging your deltoids.